To improve is to change, and to be perfect is to change often. So it's the reason why we have evolved from 3 ports to 2 ports to single port. Look at this picture. This is a conventional approach. This is where a picture from our beginning, a 3-port technique, and this is the position we had. It's not an anatomic position. It's not ergonomic because we have to open out our arms and work in this position. If we look to this is the Uniportal approach, and this is more ergonomic, more anatomic. Then what we did was to think about. And why about the view we have with the Uniportal approach? The view is the best possible. It's the most anatomic view. It's direct to the target tissue. This is an example of how we open the fissure from the anterior part of the lung, because we have a direct visualization. And another issue is the mathematical and physical demonstration of Uniportal VATS. And why? Because the 3-port technique, the conventional VATS, creates a new optical plane with genesis or torsion angle, and this is not favorable to the bidimensional monitors. There is a physical and mathematical demonstration about why Uniportal is better, because what we do is reproduce the open maneuvers inside the chest by looking to a monitor. Probably the new investigations will try to demonstrate that the ergonomy and the pressure during instrumentation is less within this approach. And that's the conclusions. Uniportal VATS preserve depth of intraoperative visualization and enables the surgeon to bring operative fulcrum inside the chest. How was the beginning of our Uniportal approach? We started to learn the 4-port technique with Rob McKenna after learning the double-port technique with David Amico, and after a previous experience of about 200 cases, we started to do the Uniportal approach. We consider important the previous experience in double-port technique because the technique is the same, but with different modifications. The utility incision we place in the 5th intercostal space is about 4 or 5 centimeter incision. We don't use trocar, and it's one of the keys and one of the points we believe that the patients refer less pain because we don't use the compression with the trocar. The key is the lung exposure, and we have some tricks to do that. We move the table, the surgical table during the operation, and that helps for the lymph node dissection and for the hilar dissection. As I said before, the visualization is direct to the target tissue. With one screen is enough, and we used to place the camera in the posterior part of the incision most of the time. It's very important to have a bimanual instrumentation using both hands, as we do in open surgery. And it's very important the coordination between the assistant and the surgeon. We usually staple first the artery because then we have better angle for the staples to the vein. And this is important to have in mind. And when we have no angle for staplers, we use the vascular clips. The material can be conventional. During a lot of time, we use conventional instruments. As this is a case of another enucleation, and we can repair by using conventional instruments. But recently, we have adopted the Scanlan instruments because they have a proximal and distal articulations, and we have improved the technique, and we have we can go faster with these instruments. This is the new dissector, specifically designed for single-port VATS lobectomy. The size of the incision depends on the lobe we have to remove. This is a radial lobectomy, and this is a pneumonectomy. So it's different depending on the lobectomy in question. Since the beginning, we published the first case, the first upper cases, the first pneumonectomies, the first series of cases in the Journal of Thoracic, the first cystectomy. Even we have published in different atlas, multimedia manual, recent textbook. We now are teaching the technique. There is a huge interest around the world about our technique. We have a course in a wet lab. I think it's the best way to learn the technique, doing the procedure in a live animal and combining with live surgery. And what are the steps we recommend from conventional VATS? The first step we recommend is to remove the posterior port. It's never necessary. I don't understand why the third port is the most painful and it's not necessary. Then I recommend to adopt the double port technique. And for lower lobectomies, we can add the camera through the utility incision because all the lobectomy is, even in double port and triple port technique, all the lobectomy is performed by the utility incision. So why not put the camera in the upper part and work below? I think is the first step to learn the technique. Use by manual instrumentation. It's very important to use both hands. And for upper lobectomies, I recommend to keep the camera through utility incision and use the inferior port only for staplers and dissection. Finally, I recommend to use the inferior port only to expose the lung, not for staplers. Try to put the staplers through utility incision. And use vascular clips when there is no angle for staplers. I recommend to start with lower lobectomies because are the easiest lobectomies with open fissure to start. And there is a way to learn from open surgery also. How is possible? Because we reproduce the open surgery maneuvers during uniportal VATS. It's the same. We only need a coordination, so it's possible. There are many surgeons around the world that have adopted the technique from open surgery. And why? We recommend have experience in anterior thoracotomy. Start with anterior thoracotomy. Then we recommend to add the camera through the anterior thoracotomy.